We have quite a few images to go through, so let's get started. I'll give you a few seconds to look at each image. The extensor mechanism of the finger is there's a single extensor tendon that divides into three parts. The two lateral parts split and then reform on the distal phalanx, the proximal pole of the distal phalanx. When you have disruption of that distal part of the extensor tendon, you end up with unopposed flexion at the DIP, and you end up with this abnormality, which is a mallet finger or baseball finger. One rule of thumb, if the image is doing something that you can't do, there's probably something wrong. Here's another example, continuing with the extensor mechanism. If you sever the extensor mechanism more proximally at the PIP, you'll end up with this deformity. What happens is the two lateral slips slip over the sides of the bone so that the proximal interphalangeal joint slips through those and like a button through a buttonhole, and this is the boutonniere deformity. Commonly when people dislocate, they'll take a piece of bone with it. One such injury is called a volar plate fracture. You need to always look on 3 views of your fingers to look for this abnormality. Usually if the bone fragment is more than 35 or 40% of the articulating surface, it may require surgical pinning. So size is important. And that's another thing that you should keep in mind when you're talking about fractures to your referring clinicians or your examiner. The size of the abnormality is important. It may be a factor. People don't do this anymore. This is, at least they don't do it the way it was originally described. It's called gamekeeper's thumb. It was reported to occur in rabbit handlers. Now the most common reason for getting this is skiing. Normally, when you get gamekeeper's thumb, you don't chip off the bone. This is an unusual case where you've actually disrupted the bone. It's an injury that involves the ulnar side of the metacarpal phalangeal joint, the ulnar collateral ligament. Now, often it's an occult injury, and you may be asked to stress the joint. What you don't want to do is stress it with external force. If you're going to do any stress on this joint at all, you want to do it with the patient doing it themselves and compare to the contralateral side. Anything more than 10 degrees different from the contralateral side or a 35-degree angulation between the metacarpal and the proximal phalanx is abnormal. The reason you don't want to add too much force at this joint is you can convert this injury from a non-surgical injury to a surgical injury. The ulnar collateral ligament, when it tears, it could remain next to the bone, in which case it would be non-surgical. However, there is a lesion called the Stenner lesion where the ulnar collateral ligament balls up and gets outside an aponeurosis nearby. And I'm sure you'll hear about that in the MRI section. It's called a Stenner lesion. You don't want to stress the joint to the point where you've created a Stenner lesion from something non-operative. So only let the patient do this themselves. Let's turn to the wrist. We use the arcs of Galula. There are 3 arcs. I've only drawn 2 here. The third one is along the proximal row. The second one is along the articular surface of the proximal row. And the third one is along the articular surface of the capitate and hamate. You want to make sure that these are nice, smooth, round curves and that the joints between the scaphoid and lunate and the lunate and triquetrum are roughly rectangles in shape. When you have disruption of the arcs of Galula, it may be a sign of ligamentous injury or fracture. In this case, we have disruption of the arc of Galula, the proximal row arc, and then in the next arc, we have overlap of the bones. There's no joint space seen at all. If we look through the scaphoid, you'll see that there's a fracture through the waist of the scaphoid. On the lateral view, you can see that the lunate is lined up with the radius, but the capitate is no longer lined up with the lunate, and this would be a perilunate dislocation. Here is another example of a perilunate dislocation. Here's the lunate, and here's the capitate. Now, if we look at our next image, we'll look at our proximal arc of Galula. We'll notice that this joint space is not the same as that joint space. This one has become a triangle instead of a rectangle. We go to our next arc and we see we run into bone here instead of a joint space. If we look on the lateral view, the lunate is facing in an abnormal direction. The axis of the lunate is facing toward the palm, and the capitate is more aligned with the radius than it is with the lunate. This would be an example of a lunate dislocation. Now, another thing that we want to look at is the distance between joint spaces. A general rule of thumb is that joint spaces at the same level are all about the same. So you would kind of expect that the lunotriquetral joint space and the scapholunate joint space should be about the same width. In this case, they're not. Another abnormality is that the scaphoid bone has a complete ring. And this is called the ring sign. And the reason you get this is the scaphoid has started to face toward the palm, and the distal pole has formed, you're seeing it on end, and you end up with it rotating down in this ring sign. The distance between these two is too great. This is what you get when you get a scapholunate dissociation, tear of the scapholunate ligament. Now, sometimes you're asked to identify this injury. One common wrist exam that we perform is an ulnar deviated view of the wrist to look at the scaphoid bone for a fracture. If you're looking for scapholunate ligament injury, this may fail and actually hide the abnormality. So in this instance, what you want to do is a clenched fist view. You want to compare it to the contralateral side. Anything more than a millimeter different from the contralateral side is indicative of an injury in this region. Now, how big is too big? In the literature, it says anywhere between 2 and 5 millimeters is the normal range. With that wide disparity, this may be, if you have a doubt, you may want to get the contralateral wrist anyway, just to compare and see what the normal is for that patient. It's always important to look at the lateral view of the wrist. There are a number of abnormalities that you will only see on the lateral view of the wrist, and it's important for you to get familiar with it. One of them is a very commonly missed fracture, and that is this case, where you see a bone fragment dorsal to the triquetrum. This is an avulsion fracture of the triquetral bone. Commonly missed fracture. Look on your lateral for that. This brings us to another subject. If you look at the lunate bone, you'll see that it is sclerotic, it is a little bit lytic, it's deformed, has a very unusual contour. This is one of the osteochondroses, maybe the result of avascular necrosis or repetitive stress injury. It's commonly associated with a negative ulnar variance. That means that the ulna is shorter than the radius, and you have abnormal stress applied to the lunate. And this is called Kienbach's disease. It's an osteochondrosis. There are a number of these, and we'll see another form of osteochondrosis later on in this lecture. The elbow is often very problematic, especially the pediatric elbow. And one of the things that you want to look at is in the flexed elbow, you want to look for fat pad signs. Here is an example of a posterior fat pad, but we really don't have an idea what's wrong with it. I don't see a fracture right on just looking at the bone contours. Whenever you see a fat pad and you don't have an explanation, you have to do a little bit of work. So one of the things we do is draw an anterior humeral line. This line along the distal aspect of the humerus, the anterior cortex of the humerus, should go through the middle third of the capitate, of the capitellum. If it goes, as in this case, anterior to that, to the middle third of the capitellum, that's indicative of a supracondylar fracture. The ossification centers of the elbow can also be very confusing. I use a little mnemonic, C-I-T-E. They form an X, C-I-T-E, and they come in at ages 1, 7, 10, and 11. So you can kind of do a little cheer, C-I-T-E, 1, 7, 10, 11. The ages are very crude, but they give you roughly the sequence that they appear, and I'll show you how we can use that. So here we have an example of a pediatric elbow. We don't know exactly what's wrong until we do our analysis. Here's the capitellum, 1. We go up, draw our line for our X. We go expect something at 7. There's 10. And we go, the rest of our X, we go to 11, 1, 7, 10, 11. So they might not be old enough to have the last one, 11, but we've skipped 7. So where is it? Down there. So you've got an avulsion in the medial epicondyle. which has gone into the joint space. So do this 1, 7, 10, 11. It'll help you a lot with analyzing the pediatric elbow. Another thing that you need to be fairly comfortable doing is ordering the contralateral joint when it's ever a question of an apophysis or a growth plate that just doesn't seem right. So here we have a very complicated view of a pediatric elbow. Some of the ossification centers, the trochlea and the external epicondyle or lateral epicondyle, are multiple. They're often come from multiple ossification centers, and so they can be really complicated looking. So this is a hard elbow to analyze. So get the contralateral one. The contralateral elbow, in this case, shows a nice small growth plate, and so this one's displaced. The trochlea is multifocal, and that's normal. You've got the bilateral aspect of that to help. There are a number of other injuries that occur at the elbow. Another line that we use in analyzing the pediatric elbow is the radiocapitellar line. The radiocapitellar line you take the distal aspect of the radius and draw a line. It should always intersect the capitellum no matter how the elbow is imaged. There's our radiocapitellar line. It's lined up. It can be very useful in analyzing these elbow fractures. If the capitellum's lined up with the humerus, the ulna's lined up with the humerus, but the radius is not lined up with the capitellum, this would be a sign of a radial dislocation. The radiocapitellar line's not lined up. In this case, humerus is lined up with the ulna, radius is lined up with the ulna and probably lined up with the humerus as well, but the capitellum is off. This indicates a disruption of the distal epiphysis. And since it goes into the joint space, this would be a Salter 3 injury. That's what's happened. So your radiocapitellar line can help you analyze this as well. Here's an example where the radius is not lined up with the capitellum, but the radius is lined up with the ulna. Capitellum's lined up with the humerus. So that means that the problem is between the radius and ulna and the humerus. So this would be an elbow dislocation. This is the medial epicondyle, 1, 7, 10, 11. This is not going to be the trochlea. This is the medial epicondyle that's been pulled off as well. We have a couple of named fracture dislocation combinations. The radius and ulna are a ring. We'll talk about this, and the tibia and fibula being a ring as well. The pelvis is a ring. When you see an abnormality on one side, always look on the other side of the ring. So the way we keep these straight, we use a mnemonic called MUGR, M-U-G-R, Monteggia, ulna fracture, Galeazzi, radius fracture, MUGR. So we have a radial dislocation, but an ulnar fracture, so this would be the Monteggia fracture dislocation combination. Here is a lateral view showing the same thing. Here's a lateral view of the wrist. And here we have the ulna posteriorly displaced. We have the radius fractured, so this would be the Galeazzi combination. Here is an AP view showing the ulnar dislocation. Now another combination is when you have a fracture of the radial head and a dislocation at the distal radial ulnar joint, and that's the Essex Lopresti. Again, when you see a fat pad sign, here we have a anterior fat pad. All you need is one, you don't need two fat pads. If you see one that's abnormal, that's enough to be suspicious and interrogate this joint more closely and find out what's wrong. So here we have a sale sign from some sort of problem. Don't see it on here. The next thing you would do is ask for a radial head view. That wouldn't be one of your standard views. You ask for that because you've seen an abnormal fat pad, you know something's wrong. Radial head view is obtained, and you can see the obvious fracture through the proximal radius, through the radial head. Again, quantitate. The treatment of the radial head depends upon how much it's fragmented and how big the fragments are. So you want to quantitate this one. I think this one's 35–40% of the articulating surface. You want to mention that. That will change the way it's treated. Distal humerus fractures, I'm just going to talk very briefly about condylar fractures. One of the critical components of the elbow joint for its stability is the lateral ridge of the trochlea. So this is the lateral ridge of the trochlea here. If you have a fracture that includes that, in other words, a fractured off fragment includes that, that's going to be less stable than a fracture as we have here that does not include that. So paying attention to the detailed anatomy is also important when you describe a fracture. Sometimes it's not enough just to say it's broken. Let's turn to the shoulder. Here we have an obvious anterior dislocation, a subcoracoid dislocation of the humerus. This is going to be clinically very easy to diagnose. They don't need us to tell them that it's dislocated usually. But the things that they do need are the other complications of the shoulder dislocation, the two fractures that commonly occur. One is caused by the impaction of the humerus on the glenoid. On the humerus, the humerus side of it, you end up with an impaction fracture called a Hill-Sachs deformity. If it's deep, that can cause recurrent dislocations by that defect getting caught in the lip of the glenoid at a certain stage of motion and then forcing the humerus into dislocation. On an MRI examination, what you would look for is a flattening of the posterolateral corner of the humeral head. The highest images of the humeral head should be perfectly round. Another thing that you're going to want in your post-reduction films is look for a lesion on the glenoid side, the scapular side of the shoulder, because at the same time that you impact on the posterolateral corner of the humeral head, you're impacting it onto the anterior-inferior corner of the scapula and breaking off a fragment here, which would be a Bankart injury. You want to look for that always. Here is an example. This is a 45-45 view, so it's distorted. It's obtained with the shoulder down and the beam angled at 45 degrees. And you see this bone fragment from the anterior-inferior aspect of the glenoid. And again, quantitation is important. This can also occur not as a bony injury, but as a labral injury. Here, this is the antero-inferior aspect of the glenohumeral joint, and this is a torn labrum. And I think you'll hear a lot about this later on in the course. Posterior dislocations can be very hard to detect, and a lot of them are missed at the time of initial presentation in the emergency room. If you only get an AP view of the humerus, you're going to miss these. Here we have a transscapular Y view with the humerus obviously dislocated posterior with respect to the scapula. It will, like the anterior dislocations, you will get impaction injuries. You will get a indentation of the anteromedial aspect of the humeral head. This is another 45-45 view. This is a very helpful view to get if you suspect a posterior dislocation. The patient does not have to move their arm. They may not be able to. They're just lying at 45 degrees on the table. The angles of the beam is at 45 degrees with respect to the plane of the table as well. And you end up with anterior-posterior information. So this is posterior and this is anterior, and the humeral head is obviously dislocated posterior. It's not aligned with this. If you're ever lost on these images, as sometimes you can be, look for the coracoid process. That'll tell you what's anterior and posterior. There is another sign that you can look at. It's called the Trough sign. That's an indentation. That's the exact parallel to the Hill-Sachs deformity, except it's anteromedial from the impaction. Here's a Trough sign. This is what it looks like on MRI examination. It's an indentation of the humeral head where it's supposed to be round, and it's a result of impaction injury. In addition to that, you need to look at the posterior labrum. That also may be avulsed, kind of a reverse Bankart lesion. So how many of you think this is a dislocation? Okay, I got no hands. Excellent. I didn't think anyone was going to raise their hands this afternoon anyway. Anyway, what you have, always look for the humeral head. This is obviously immature skeleton. Humeral head remains aligned with the scapula, but the humerus is not aligned with the humeral head. So this is just a growth plate injury. It's a Salter 1 through the growth plate. Now, if there's a little bone, an extra bit of bone attached to this, it might be a Salter 2, but it's not a dislocation. Acromioclavicular joint, we commonly use 3 grades. There are 3 more that basically add sort of direction to the dislocated clavicle with respect to the acromioclavicular joint. The first one, grade 1, is just pain but no separation. Grade 2, separation between the acromion and clavicle greater than 3 to 5 millimeters. Grade 3 is abnormal separation between the coracoid and the clavicle because of disruption of the coracoclavicular ligaments. And the other 3 grades I'm not going to burn you with, they're in the syllabus, but they're basically different places for this clavicle to be, under the coracoid or behind the coracoid or up through this, the muscle into the subcutaneous tissue. If you ever have suspicion for acromioclavicular injury, the best thing to do is to compare with the contralateral side, everything on the same film, get with and without weights, the person holding or not holding weights, get those, and then look at the difference between the 2 sides. If there's more than a 2 millimeter difference between the AC joint on one side and the other side, that's a problem. If there's more than 5 millimeters difference between the coracoid and the clavicle from the 2 sides, that's a problem. Let's turn to the lower extremity. I'll give you a minute to take a look at it, get reoriented now that we've switched to a whole different part of the body. So what we have here is an abnormality of the second metatarsal phalangeal joint. And if you look, the bone is expanded on both sides of the joint space is narrowed, there's hyperostosis, there's flattening of the head of the second metatarsal. So this occurs in people who have a congenitally long second toe or people who wear high heels in adolescence and young adulthood. This is called Freiberg's infraction. It's another one of the osteochondroses. It's a result of avascular necrosis / repetitive stress injury. When people start changing their activities, say they start running and they run, they haven't been runners and they run 1 mile a day they start out that way, and all of a sudden they start feeling really good and they say, I'm going to kick it up. This day I'm going to ride 5 miles. I'm going to run 5 miles. And then they start doing that every day instead because they've got the wind. That abrupt change in activity, going from 1 mile to 5 miles, your bones can't handle that. They're constantly remodeling. And so you end up with a stress injury as a result of that. When people first get imaged, often they come in when they first start having pain. And the bone findings are often negative at the time that they present, when they first start having pain in that first 2 weeks. It may take 3, 4, or 5 weeks before you start seeing the signs of a stress fracture, which would be a radiolucency at first, maybe some periostitis, and then maybe later some sclerosis, perpendicular to the long axis of the bone. Here is a case where we have periosteal reaction along the second metatarsal of the classic March fracture or stress fracture. There are a couple flavors of fifth metatarsal fractures, and it's important when you can talk to the emergency room about which one you're talking about. They have different treatments. When it's just an avulsion of the tip, the person is put in a hard shoe and they're allowed to walk on a hard shoe. They're not on crutches. This is the avulsion fracture. It's where the peroneus brevis tendon attaches and the plantar aponeurosis attaches, the lateral aspect of plantar aponeurosis. Both of those may contribute to why this pulls off. A fracture more distal, usually between 1.5 and 2 centimeters from the articulating surface, is called a Jones fracture. This person is going to be on crutches, and they are not going to be allowed to bear weight. So it's important to distinguish between these two. This has a much higher risk of going on to non-union if it's treated the same way as the avulsion injury. Let's next turn our attention to the Lisfranc joint. The Lisfranc joint is between the between the tarsal bones and the metatarsals. Normally, the second metatarsal perfectly aligns up with the central cuneiform. The first metatarsal perfectly lines up with the medial cuneiform. And on this AP view, the fourth metatarsal is going to perfectly line up with this edge of the cuboid. The third metatarsal is going to be hard to see on this view. It'll be more easily seen on the oblique view. There is a ligament that connects the medial cuneiform with the second metatarsal. That's called Lisfranc ligament. So in this case, you can see that there is not a proper alignment of the first metatarsal with the medial cuneiform, and the second is not lined up with the central cuneiform. On the lateral view, the metatarsals are actually dorsal to the tarsal bones. That's always wrong. Metatarsals should never be dorsal to the tarsal bones, their respective tarsal bones. So this is disruption of the ligament. Now, this is an obvious case. It's a very common injury to miss. If someone says, I think they have a Lisfranc ligament injury or a Lisfranc joint injury, what you need to do to interrogate that is do a weight-bearing view of both feet. With a weight-bearing view, if you see more than a 1 millimeter difference in the space between these two bones, or you see offset, that will be a sign of ligamentous injury. It's a very commonly missed injury, so you always want to interrogate it, ask for weight-bearing views. Now, sometimes it's not the offset in this direction, but these two surfaces should be parallel, and here they're divergent. And there's also some bone chipping in here. This is a sign of a Lisfranc injury. Sometimes your only clue that there's an injury here is by seeing a little bone in here, and that can be an avulsion injury from the first metatarsal or from the medial cuneiform or from the second metatarsal. Any of those could contribute to that. I think it's most commonly an avulsion off of the first metatarsal. You have to be careful with this. There is an os intermetatarsalis that exists here. So you have to, whenever you're looking at bone chips, you have to look at the quality of them. Look for the edges. Is it round, like a pebble rounded in a stream? Then it may be normal. If it's got a frayed edge and you can see a donor site, likely fracture. Sometimes you just can't tell. Here's an oblique view of the foot, and you will notice that here's the cuboid bone, and here is the fourth metatarsal, and it's not lined up. It's not always the first and second metatarsal that's the problem. Sometimes it's one of the other ones that's an abnormality. So it's in your book, but on the oblique view, the third and fourth metatarsals should perfectly line up with their respective tarsals. On the AP view, the first and second should be perfectly lined up. You see those very reliably on that view. And on the lateral view, none of the metatarsals should be dorsal to their respective tarsal bones ever. Another stress fracture place that athletes get is in the navicular bone. Here is one that's gone too far. It's gone to a complete fracture through the navicular bone. Navicular bone commonly fractures here. It will also can be seen fractured in a horizontal plane, and you'll only see that on a lateral view. And that's about all I'm going to say about that bone. Whenever you have the history ankle sprain and you get an ankle series, you always want to look at the lateral process of the talus and the anterior process of the calcaneus and the base of the fifth metatarsal. You always want to look at those three structures in addition to looking at everything else normally. Do a double look for those. They will present as ankle injury. So one of them is an avulsion injury, the anterior process of the calcaneus. There's a bifurcate ligament that connects the anterior process of the calcaneus to both the navicular and to the cuboid bone, and it is avulsed with an abrupt ankle turning. Now, unfortunately, there's another one of those pesky osses. I don't have a name for this one, but you have to look at the quality, look at the donor site. In this case, this is round, these are round, this is normal. If you have any doubts, you can get the contralateral side. A lot of times, secondary ossification centers are bilateral. Let's turn to calcaneal fractures. Okay, we use the Saunders classification for calcaneal fractures, and not everybody uses this. We just like to communicate whether it's a 1 or a 2 or a 3-part or a 4-part fracture. The way we use the system is you take the talus, the posterior facet of the talus, the widest part of it, and you divide it into 3. You add another line on the medialmost aspect of that, and then you extend all of those lines into the calcaneus. And this gives you 4 columns. This is a lateral column, central column, medial column, and the sustentaculum talus. If these segments are separated from each other and there's disruption of the articulating surface, it becomes a 1 or a 2 or a 3 or a 4-part fracture. And I'll give you an example. Here is an example where if we drew our lines, we would see that we have one part of the calcaneus separated off, the lateral column, from the central and medial, and then the sustentaculum talus is going to be over here on more anterior images. So this would be an example of a 2-part fracture. As we go forward on that image, we can see that 3 of the columns are in continuity. They're one fragment, and the lateral column is the only one that's separate, making this a 2-part fracture. Doesn't matter how much is busted here, it's the articulating surface that's important. This was a 3-part fracture. The sustentaculum talus and the medial column are one fragment, but the central column and the lateral column are separate. And so this would be a 3-part fracture. Another thing that you want to look at with calcaneal fractures are tendons nearby. Calcaneal fractures can be blown out into multiple fragments, and a lot of times tendons can be incarcerated between those fragments. I'm going to draw your attention to 2 that you want to pay particular attention to. One is the flexor hallucis. Here's an arrow showing a fracture line between the sustentaculum talus and the medial column. That's the flexor hallucis right there. The tendons are often brighter than muscle, and often they're surrounded by fat, so you can identify them as separate from the other structures around the foot. What you don't want to have is that flexor hallucis stuck, like in this case, between bone fragments. If it's there, you want to let the referring clinician know that you've got an incarcerated tendon between the bone fragments. The other one that you want to look at is the perineal tendons. Often the lateral column is blown out into a bunch of fragments, and the perineal tendons hug the lateral cortex of the calcaneus. Here are the perineals, the brevis and longus are here, and you want to make sure that they're not trapped between bone fragments. Here is another side, very comminuted fracture of the calcaneus. Perineal tendons are outside, not incarcerated. I'm going to go very quickly over ankle injuries. There's a system I like to use just because it makes me look at all the main points of the ankle, the Logge-Hansen system. It's used, it's a mechanistic approach to analyzing the ankle. The main thing that I take from it is there are 3 main things that I want to look at. I want to look at the fibula, I want to look at the medial malleolus, and I want to look at the posterior lip of the tibia in all of these cases. You can kind of predict the pattern of injury knowing this approach, but it's not necessary that you know the system. This happens to be supination adduction. The first stage is a fracture of the fibula at or below the joint space. The second is a vertical fracture of the medial malleolus. What happens is the talus rotates this way. It pulls this off and it goes up there. This is the first injury, that's the second injury. You don't have to have the second injury. You may just pull off that. Typically, the way to recognize this mechanism is a transverse fracture of the fibula at or below the joint space. The next one is another injury that begins on the lateral side. This is supination external rotation. This is a 4-stage process. I think the main thing to understand about this is the fracture begins again at the joint space right here at this corner of the fibula. It's a 4-part mechanism, and I'm going to skip through these quickly, but the 3rd part involves a very subtle injury of the posterior aspect of the tibia. Whenever I see a fracture of the fibula that looks like this, it starts here and goes up that way, starts there and goes up that way, I always look really hard back here at the posterior aspect of the tibia. That's an occult injury. If it goes on even worse, you'll get medial malleolus disruption. The pronation injuries have fibular fractures very high. This is a pure eversion injury. You get comminution and you get this little triangular fragment. This would be a pronation abduction injury. With the pronation injuries, when the fibular injury is high, usually the medial malleolus is the starting point. The injury starts on the medial side. So you don't have to go to these other stages. This is the first thing that happens. This happens to be a 3-stage process. You disrupt the ligament in between these two bones all the way to the top. This is the important one. This is a pronation external rotation. The reason this is important is that you may not see this fibular fracture. The injury starts here with a transverse fracture of the medial malleolus and then works its way around. It will involve the posterior tibia, so you always want to look there, and it'll involve the fibula somewhere. For me, knowing the sequence that the posterior tibia is last in this 4-stage process helps me because I'm going to be looking for that fibular fracture really hard when I see a transverse medial malleolar fracture and a fracture of the posterior tibia and I don't see anything on the fibula. Something's missing. Here is how I use it. So here we have too wide of a space here. Normally this is 4.5 millimeters. If it's wider than that, that means the deltoid ligament's disrupted. This may be too wide. This is broken. But I don't see a fibular fracture. So this is a case where you want to say, give me a knee film. And here's the fibular fracture way up there. This is a Mason nerve injury. So that's how I use it. Look at the medial malleolus, look at the lateral malleolus, look at the posterior aspect of the tibia. This is a ring structure. If you don't see something wrong with the fibula, shoot the knee. Okay, let's go on to the next one. Another thing that you want to look at with ankle injuries, sometimes you'll shear off the talar dome. This is an osteochondral defect of the talar dome. You always want to look for that on ankle series. You will interrogate this with MRI. What you'll be looking for is fluid, dissecting the bone, and that means that it's unstable. Another injury that's really common now is a lateral process of the talus. This is a really obvious case. Sometimes these are very subtle. They're just a horizontal line through that. You see it in snowboarders. So always look at the lateral process of the talus when you're looking at ankle series. In kids, they have a maturation pattern where growth plate fuses from medial to lateral of the tibia. So they get a unique fracture called a juvenile to low fracture. And in kids, you have to look really carefully. It's usually late, 10 to 15 years old. Look for, very carefully right back here, you will get a Salter 3 fracture just on that aspect of the tibia. Because of the rate of maturation, that's the weakest part. This hasn't fused yet, this is fused already, and always look there on adolescents for ankle injuries, juvenile to low. Let's turn to the knee. Sometimes people will present with pain. They say they think they dislocated their patella. What you look for is disruption of the ligamentous structures here, and you look for bone bruising here and here. That would be a sign that the patella has done that. Just like our Hill-Sachs injuries and you get impaction on the patella and impaction on the lateral aspect of the femur. From that, here's a gross example of edema. The other thing that you want to look at is look for a cartilaginous defect in the apex of the patella. There are a number of posterolateral supporting structures and lateral supporting structures that you want to look for in your MRI examinations. Iliotibial band is there. The lateral clapsolar ligament is there. The arcuate ligament, the fibellar ligament, and the biceps femoris. thing I want you to pay attention to is this little chip near the lateral tibial plateau. Always look for that. When you see that, that can be a sign of lateral instability. It also can be a sign of ACL tear. And here on an MRI, you can see disruption of the fibular collateral ligament, but the fracture of the lateral tibial plateau you can't see. You may only see this on plain films. Avulsion injuries of the lateral tibial plateau can be very occult. They don't induce a lot of edema in the underlying bone. And so whenever you have this problem, always look at the plain films in addition to your MRI. This is a very significant injury in that it's a marker for this, an ACL tear. We have a complete tear of the ACL. And that plain film finding of the Supine fracture may be your clue that they have the ACL tear. Here's another example where you have a Supine fracture and undermining of the tibial eminence from an ACL tear and a Supine fracture. Whenever you see a fat fluid level, you want to interrogate the knee further because you've got something producing marrow fat into the joint space. In this case, we have a compression fracture of the lateral tibial plateau. There is a system we use called a Schatzker system. You don't have to memorize that, but it basically divides lateral tibial plateau injuries from medial tibial plateau. This is a Schatzker 4. This is more unstable than anything that happens on the lateral side. Let's turn to the pelvis. When you have a direct anterior blow of the pelvis, you will initially disrupt ligaments anteriorly. In this case, we have an anterior compression, and you have widening of the sacroiliac joints. These two lines should be parallel, not divergent as they are here. So we've got disruption of the anterior sacroiliac ligaments. When the symphysis pubis is more than 2.5 centimeters wide, that is scream calling the emergency room time. This is a very critical injury, more than 2.5 centimeters. You can't do this without severely disrupting the posterior elements of the pelvis as well, and this is a high correlation with severe bleeding and death. So more than 2.5 centimeters of symphysis pubis widening is a critical thing. The other thing you want to look at on pelvis images for lateral compression injuries, you always want to look at the arcuate lines of the sacrum. They should be smooth. If you have a force coming from this direction, it may buckle, as it does here, the sacrum. And that would be a sign of a zone. In that case, that was a zone 2 injury. This is what you look for on a CT examination, this buckling of the cortex. This surface should be very smooth. The last thing we're going to talk about is vertical shear. You have vertical displacement of one versus the other one. Here is a CT example. This requires complete disruption of the sacroiliac joints. Very serious injury. Again, high association with mortality and heavy bleeding with vertical shear injuries. Here you can see the sacroiliac joint on this side, which is normal. This iliac bone is up here and the sacrum's down there. Everything's disrupted, vertical shear. Acetabular fractures, you want to divide. I'm just going to talk about two. Transverse fractures separate the wing from the ring. Here is the fracture. On CT examination, this fracture goes from front to back, separating the wing, which is going to be out here, from the obturator ring. At the level of the acetabulum, transverse fractures go from front to back through the acetabulum. The other form I'm going to talk about is the anterior column fracture, in which case you disrupt the iliopectineal line, you leave the ilioischial line intact. On a CT examination, these fractures separate the acetabulum into front and back halves. That's an anterior column injury. The last thing I'm going to say is that whenever you have a fracture, try and figure out why they broke it. If you look at the cortex of this injury, you can see that it's very eroded, and that's because of metastatic disease.